with Professor TITIYAL. Professor TITIYAL is going to talk to us about intraoperative imaging technology for the corneal surgery. So, over to you, Dr. TITIYAL.
Thank you very much, and good morning, friends. Indeed, it's a real honor to be amongst the cornea people sitting in this hall, because things have changed so much in the last few decades. It's become quite a significantly glamorous surgery in ophthalmic area also. And when I got a call from Dr. Somshila that you have to speak on intraoperative imaging, it was my delight, and thank you, Somshila, for inviting me for this particular symposium. I think it is important to see things clearly, as Dr. Basak talked about. If you see, you imagine, then you can implement that in your surgical scenario, and you achieve the success in these cases. Intraoperative imaging was possible because of OCT attachments. It can be handheld OCT systems, or the new microscope which has come with the OCT attachment, which will give you not only the imaging of the entire ocular structure of the host and donor, also will give you a dynamic relationship between whatever you are doing at that particular stage into surgery, and tells you the interaction of your surgical steps with the tissue interaction. That is a major advantage of intraoperative imaging, which will change your attitude towards the surgical approach in that particular scenario. And this was a survey article we published, the review article in 2020. And mostly it were most of our studies in that particular case. But if you read this, you get a lot of insight into an entire gamut of anterior segment surgeries based on IOCT microscopes. You all know this attachment of OCT in the microscope was mainly supposed to be for retina surgeons. But now we realize it has a lot of implication for corneal surgeons also. Now this is one scenario: you're doing a lamellar keratoplasty and you're not sure if you reach the depth. So this, if you can image this, you can always see how far you have reached, how deep, and how much you have to go subsequently to achieve the desired depth is very, very critical in these cases. Similarly, if you are doing an anterior lamellar keratoplasty, you need to know if you have removed the entire depth of a lesion or opacity, and that can only be possible by scanning the cornea with this OCT microscope. Because simple operative microscope will never give you that analysis of lesions which are present in a corneal stroma, and even you have a retroillumination, very difficult to pick up. Similarly, as Dr. Basak talked about endothelial keratoplasty, there are many steps which may not be ideally visible. You may have to do so many things to see that what has been done. Like in a cornea like this, the Descemet scoring can be difficult sometimes. Even after scoring, I could see the Descemet is still attached in some areas. So this will give you a guide. You have to re-enter and redo the entire descemetorexis in cases where you have such a difficult scarring happening and complicated pseudophakic patients. So this is one scenario we have all been talking. Is your graft well attached? Has it been attached quite comfortably despite putting air pressure for more than 10 minutes? And this is what you can see. Still after that, the graft is not attached. You have an interface space still there. So this tells you have to do something more, maybe a staph incision, maybe there's a fluid. So this type of orientation, which Dr. Basak talked about in EK with DMEC, this tool gives a lot of visibility inside the anterior chamber. You know that what is the right orientation of your graft. So this IOCT is basically a surgical biopsy on the table, the in vivo optical biopsy, which gives you understanding of the diagnosis which have been made pre-operatively by your examination slit lamp or anti-segment OCT, and it can change the planning of surgery on the table by monitoring the various steps. For anterior lamellar keratoplasty, what we do a scanning of entire cornea first, see the depth of opacities. You can know the depth, thickness of cornea also. Accordingly, you pick up if you are doing a microkeratome assisted, you can pick up the right size of keratome head and do the surgery in these cases. And achieving a clear, smooth surface is mandatory, and which is possible with microkeratome. Both host and donor can be nicely customized to fit into this, and subsequently you can do a sutureless surgery in these cases. In this case, I'm doing automated microkeratome assisted cutting of a corneal tissue of around 150 microns, and this tells you that your diseased tissue has come out. So that is the advantage you have, and more importantly, for a deep lamellar keratoplasty, it gives you a much more visibility. If you see here, the entire descemet can be seen after you inject the air. Descemet has fallen down towards the anterior chamber. As you make a nick, the descemet will come up, and this tells you that your big bubble is completely filled. And after completion of your suturing also, you know that descemet is well attached. There's no double chamber, which may be a possibility in these cases. So every step of a dal can be seen, and you can modify your approach subsequently also. And to summarize, the anterior approach with visibility with a microkeratome or surgical dissection, both pre-op, intra-op, and post-op, it is really handy. Especially layer-by-layer dissection becomes very, very simple in these cases. What about endothelial keratoplasty, DSEC and DMEC? We all know you can prepare the donor tissue, as Dr. Basak is so experienced. He can titrate the donor thickness by his manual dissection also. For microkeratome, you can always think of if you can achieve good in a one single pass, yes, but you can do a double pass technique, and that can only be possible by actually looking to the corneal thickness. And after you cut the tissue, this tells you that how much you can do for this particular case. This single pass gives you around 100 micron thickness. The uniformity can also be seen. If you require, you can always take away the another cut from other side also. Host also, sometimes you know that in Indian scenario, the cornea can be so thick, mainly because of epithelial hypertrophy. That can be picked up nicely, the scarring can be picked up. You can decide the beyond the cornea also, looking for peripheral anti-synechial, the pseudophakic condition, all can be seen. Intraoperatively, descemet scoring can be visualized, and you can complete the scoring also. And this sign we described with IOCT, if you have a graph orientation like this, the acute bevel sign, that means the endothelial site is correctly positioned in the anterior chamber, then you are sure that it can be done in an appropriate manner. Similarly, this study is one of the, I consider a good study where we could titrate how much intraocular pressure with air bubble to be injected, how long after putting a DSEC graft. So we did a case control study, looked for 3 to 8 minutes with intracameral pressure and superficial massage. We realized the graft gets attached within the first 3 minutes. So you don't have to wait for 10-12 minutes where you can have a compromised optic disc also. Apart from that, we realized you don't have to put a staph incision in your cases because interface is absolutely clear. There are no, you can say, pockets. So these are very, very important aspects of looking into these cases. The first important thing is to look the thickness of a donor cornea. Accordingly, you choose the keratome head, and that will give you a nice cut subsequently. This is a Gibor microkeratome, which gives a very nice cut. After I remove this, you can see how beautifully the donor tissue is. Normally, sometimes you have the peripheral area a little thicker and central little thinner, but normal cut is around 10.5 millimeters. So you can always take 7.5, 8 millimeter, which will be very, very smooth cut as such. And you can take this into any technique. It can be a glide, it can be a forceps, it can be taco. But once you take this tissue inside, you can see I'll be pulling this. This is the ILM forceps. Hold the tissue outside, nudge onto the incision side, then pull the graft inside gently. At this time, keep the infusion very, very slow. Otherwise, graft may flip in a thin corneas. Then you can assess what is happening inside. The graft is not folded yet. Increase the fluid, graft will get unfolded, and subsequently you can see it is well attached. So this is the importance of seeing what is inside happening during your procedure. And imaging has changed so much in endothelial keratoplasty, DMEC or PDEC also. You can see a nice correct orientation. Dr. Basak showed this is not a correct orientation. This graft you have to flip again, and this is the correct orientation subsequently, and you can complete the surgery without putting a stamp onto the this very thin tissue. This is what we have seen, we have published. This is Dr. Namrata Sarma's paper. The DMEC in a hazy cornea is possible because as younger people will realize sometimes very difficult to see what is happening inside the roll. People will jump into DSEC surgery, but the experienced surgeons have gone to doing a DMEC in all the difficult cases also. So this is to summarize, intra-op visibility makes really possible all types of endothelial keratoplasty, lamellar keratoplasty also. This is a work, again, Dr. Namrata's work with the one thesis candidate, where actually this is the real advantage of intraoperative imaging in pediatric cases, because you don't have a good assessment in pre-op conditions. On the table, you can assess these cases. It modifies your approach for surgery. You can have a better diagnosis of these cases. You can summarize all the findings and change your surgical approach for these cases. I would say pediatric cases, the intra-op imaging is really, really important. If not IOCT, even a UBM will be helpful in these cases. The limitations are there with IOCT, and that will be a future way to look into. Just to summarize, IOCT, if you have access, really changes the concept of a surgeon, the cornea surgeon, in various aspects of surgery and diagnosis also, and achieving good results in these cases. Future would be to have a better you can say co-optation of these systems, where you can have intraoperative calibration to see the thickness, measure the volumetric analysis of these cases, because just at present time the volumetric analysis is not possible in these microscope. Sometimes the microscope, you can say focusing and movement can be halted by your OCT imaging in these cases. But if you have now the access to a digital microscope, 3D microscopes with a larger viewing system, that also made very easy visibility of surgeon. You can see both OCT and microscope picture very, very clearly, rather than looking through the ocular. Sometimes it may give you a very hazy picture. Some assistant has to tell you from the Callisto image that what has been seen. So that is taken away by the digital 3D microscope now. Thank you for kind listening. I think you have to see what is happening inside in your thoughts, and that will translate into the microscope, which has the OCT in the operation theater. Thank you again.
Thank you, Dr. TITIYAL. That was wonderful talk, and I wish that we all have such kind of devices which can guide us, and thank you very much. In future, with the companies bringing down prices, I'm sure this won't be a distant future that we all can have such devices.